But where can we learn most from weight-bearing CT? Well, the three categories that I use it most frequently are hallux valgus deformities, bunion patients, progressive collapsing foot deformity, or patients that are particularly going to undergo surgery for surgical planning. I'll show you cases of that. And in my patients with ankle arthritis, less common, and that's maybe just simply the reflection of my practice is cavo varus deformities, where I'm reconstructing a flexible or a rigid cavo varus deformity. Midfoot arthritis, when I'm deciding which joints to fuse. Am I going to fuse 1, 2, 3 tarsal metatarsal joints? Am I going to fuse an navicular-cuneiform joint? How do I make that decision? Where is the deformity, particularly when they have loss of their arch through the midfoot? Where am I fusing and how am I going to do that? And especially for our Charcot patients, because then really we're looking at a complex deformity and how are we going to correct it to give patients a plantar grade foot. You can also use it in trauma, and I do a little bit less of this, even more so in terms of the subtle Lisfranc injury. Is there some subtle diastasis that needs to be stabilized? The subtle syndesmotic injury, or somebody who's had a syndesmotic injury and has persistent pain after surgery, and you want to compare to the contralateral side. Is the syndesmosis wide? Is there some subtle diastasis that is placing an increased strain on the ankle that can benefit from a revision operation? It also allows us to better assess certain pathologies, and this is across different patient categories or issues. So you can really look at a bony impingement when patients are applying a load through the ankle and foot. You can see how the bones are interacting with each other. So is there impingement in the subtalar joint, in the subfibular region? Is there impingement in ankle replacement in the gutters? Again, we can look at ligament stability. I just mentioned Lisfranc widening. You can compare it to the contralateral side. Syndesmotic injuries, midfoot collapse. You can look at the subtalar stability in a patient with a flat foot deformity. Is there instability at the subtalar joint that needs to be stabilized with an arthrodesis? You're getting a better sense of alignment. Not only alignment in what we conceptualize as the AP and the lateral, but you're looking at rotational malalignment and deformity. And again, you're able to assess arthritic changes in a more detailed way compared to plain radiographs.